good day to everyone. Um, it's me again, Francis Moche, Mwanakasale. We're still looking at mental health and psychiatric nursing. Last time we discussed one of the psychoses as dementia. However, we're still on the same psychosis. So today we'll be looking at MANIA. Therefore, you're welcome to this tutorial. MANIA is still on unit 3.3 in the mental health and psychiatric nursing. Now, before we go into details, we are looking at affective disorders or mood disorders. And one of them is mania, another one is depression, and some bipolars. Now, before we look into these conditions in detail, I would love us to understand two main terminologies. There is the word mood. There is also another word, affect. Now, let's look at the introduction. So we're saying mood is a pervasive and sustainable or sustained feeling tone that is experienced internally and that influences a person's behavior and perception of the world. What are we saying? So mood is an internal feeling. However, most people will be able to present their mood to the outside world. You can actually find some cases where someone's mood inside there, maybe they are not happy, but in their expression, they will show as if they are happy. That one usually we say the mood and the affect are incongruent. But to those that show the actual feeling they have internally to the outside world or the way they perceive the world, we can say the mood is actually congruent to the affect. I've brought another terminology here, affect. What is this affect? Affect is the external expression of mood. In simpler terms, the way you present yourself to the outside world or to the other people, that is the affect we are referring to. That's what we are saying. A number of people, their mood will be congruent to the affect, meaning that the way they are feeling internally, they will also present it to the outside world. But there are others that have incongruent, their mood being incongruent to the affect. For example, someone inside, they are angry as in ANGRY, but they are smiling to the outside world. They are misrepresenting their internal feeling. That's what we mean, that their mood is incongruent to their affect. So in this condition we are going to look at today, it involves the two weights, mood and affect. Now let's look at this mood. Mood can be normal, mood can be elevated, mood can be depressed. Those that have got normal mood, usually they experience a wide range of moods and have an equally large repertoire of affective expression. They feel in control of their moods and affects. Those that are usually have normal moods, they're usually in control and they feel in control of their moods and affects. Those whose mood is elevated, usually they don't feel being in control of their moods and affects. they are usually in hyperactivity situations. Those that are depressed, they are also not in control of their moods and affects. So it's either one is depressed, going down to the negative, or they are somewhere having the normal mood, which should be a range, but these usually are in control of their moods and affects. Those that go more on the positive side, where the mood is elevated, they are usually not in control. They're in hyperactivity situations and not in control of their mood and affect. Those that are depressed, they are also more on the negative side, but they are also not in control of their moods and affects. Now, mood disorders are a range of conditions in which the most prominent symptom is elevation or depression. Like I said, it's either one has an elevated mood, more on the positive side in the hyperactivity situation, or one is around the normal where there is a range. These we say they are usually in control of their moods and affects. Those that have their moods that is elevated, they are not in control of their moods and affects. Those that are also depressed, they are not in control of their depressed state. So these mood disorders can be known as affective disorders as well. So a disturbance in mood is predominant feature of mood disorder, because it means that once your mood has changed, even your affect will follow suit. So mania is characterized by an elevated, expansive, and irritable mood. So because of an elevated mood, a manic patient will create abrupt and dramatic changes in the word's climate. Now, when we say mania is characterized by elevated, expansive, what we mean by expansive is generally frank and being communicative. How about being irritable or having an irritable mood? We mean having or showing a short tendency or showing a tendency to be easily annoyed. Meaning that a manic patient can highly be communicative, can easily be irritable. So the patient is likely to interfere in the activities of his fellow patients in the ward and the staff alike. Now, before we go into details of looking at mania, can we have some objectives that students should have in mind? At the end of the lesson, students should be able to acquire knowledge about mania and how to manage a client with mania. Specific objective at the end of the lesson or tutorial, students should be able to define mania. They should also be able to state the etiology of mania. They should be able to mention the clinical features of mania. They should also be able to state the management of mania. Definition. What is mania? Mania is an affective disorder where there is an elevated, expansive, or irritable mood characterized by psychomotor acceleration, pressure of speech, and grandiose ideas. Now, we've mentioned the elevated mood already, what it is. We've discussed the term expansive. We've also looked at the term irritable. So how do these people with mania present? They will have some psychomotor acceleration. They will also have pressure of speech. They would want to talk continuously. They would also have some grandiose idea. Someone feels like they are highly placed in society, which is actually not the reality. That is grandiose idea. The other definition says mania is an affective disorder which presents with elation of mood and increased psychomotor activities. So we're saying these manic patients, there are times, it's not every time that their episode is always on the hyper side throughout. They have at times when their episode goes a little bit lower. So we're saying a manic episode is a distinct period of an abnormally and persistently elevated, expansive, or irritable mood lasting for at least 1 week, or less if a patient must be hospitalized. So we're saying when a patient with mania is hospitalized, at least the manic episode might not take even a week. But if they're not hospitalized and not under treatment, the episode might go for 7 days. These same manic patients, there are times when they have a hypomanic episode. This one lasts at least 4 days and is similar to a manic episode, except that it is not sufficient severe to cause impairment in social or occupational functioning. And usually here there are no psychomotor features present. So a hypomanic episode, this person who has mania, but when they're in hypomanic episode, they can socialize well. They can also occupationally function well because they don't even have psychotic features. But the one who has hypomanic episode, they will have difficulties in socializing because of the grandiose ideas, pressure of speech, also psychotic features, hallucinations, delusions. So for them to socially or occupationally function, it becomes difficult. So when this manic patient is in a manic episode, they will have psychotic features. It becomes difficult for them to function occupationally and socially. But when they are hypomanic, because they are lacking psychotic features like delusions, hallucinations, and they also, meaning they can also function occupationally nicely and socially. So both mania and the hypomania are associated with inflated self-esteem. That's a common feature. Decreased need for sleep. Distractibility, great physical and mental activity, and the over-involvement in pleasurable behavior. So I say both manic and the hypomanic patients, they will have inflated self-esteem. They will have those grandiose ideas. They will both have decreased need for sleep. Distractibility also will be there in the two. They will have great physical and mental activity. And they will also ensure that they over-involve themselves in pleasurable but regrettable activities at the end. An example is where someone, maybe they have a lot of money, they involve themselves in erroneous expenses, but at the end of the day, they'll complain that their money has finished. But they were spending because they were actually finding pleasure in doing so. But at the end of the day, they will regret because the money is actually finishing. That's what we mean when we say they will over-involve themselves in pleasurable but regrettable behavior. Now, according to the Diagnostic Statistical Manual of Mental Disorders, 4th edition, that's text revision, which is abbreviated as a DSM-4 TR, which was brought up by the American Psychiatric Association, APA, in 2000, though there is a latest DSM-5 TR, which was brought up in May 2013. So according to DSM-4 Tiara, bipolar 1 disorder is defined as having a clinical course of one or more manic episode and sometimes major depression disorder. What are we saying? According to the American Psychiatric Association, through their DSM-4 text revision, they say that one who has bipolar 1 disorder should have one or more manic episodes and sometimes a major depressive disorder. So there should be one or more manic episodes, and sometimes this patient should have a major depressive episode. Then that we're going to refer to it as bipolar 1 disorder. Now, the same DSM-4 text revision, according to American Psychiatric Association of 2000, they stated that one who has bipolar 2 disorder, this one should have episodes of major depression and hypomania rather than mania. So someone with bipolar 2 disorder should have more episodes of depression and hypomania, not mania. They should have more episodes of depression and hypomania. Then that one is going to be referred to as bipolar 2 disorder. Remember bipolar 1 disorder? This person should have more of manic episodes and sometimes major depression episodes. Then that will be bipolar 1 disorder. Now let's look at the etiology of mania. The cause of this condition is actually unknown, or it's idiopathic. However, there are predisposing factors to this condition. The first predisposing factor is heredity. This condition is hereditary acquired. Instances of mania is higher in the maternal side. So first degree relatives or children of people with these disorders are more likely to develop the mood disorders than people in general population. Who are these first degree relatives? Usually these are the children to the actual patients with mood disorders like mania. So the actual children that are born from these people with mania or mood disorders are more likely to have mood disorders like mania. The second predisposing factor is biological factors, where we find intracellular sodium concentration, which increases during the illness and returns to normal with recovery. So high levels of norepinephrine, serotonin, and dopamine are associated with mania. If you remember very well from your anatomy point of view, is that dopamine is both a hormone and a neurotransmitter. It's a neurotransmitter in the cerebral cells, which is involved in a number of activities. So people with a lot of dopamine, a lot of serotonin, a lot of epinephrine, they are highly predisposed to having mood disorders like mania. The other predisposing factor is psychological causes. What are these? Emotional and physical trauma, such as having a bereavement, that's the loss of a loved one, can predispose one to have a mood disorder. Disruption of an important relationship or severe accident injury may precede the onset of bipolars or mood disorders. It depends on how treasurable one looked at the relationship they had. It could be of friendliness, a relationship of intimacy, but the disruption of that relationship that is deemed important can actually predispose one to having mood disorders like mania. There are also physical factors that are believed to cause or to lead to one having mania. These may include side effects of drugs, infections like HIV and AIDS, and encephalitis, and also neurological disorders like brain tumors and head injury may predispose one to having mania. Now, what are the clinical features of mania? People with mania have grandiose ideas, that is, ideas of self-exhaustion. For example, they tell you the Republican president is my father. They just tell you something that is not even in reality. They are also talkative. They would want to have a situation where they speak continuously, which we are referring to as pressure of speech. They also go through chance association, meaning that they comment on anything within their sight. Now look at this, a combination of pressure of speech and chance association. Can such a person give you space to say something if you're having a debate or an argument? Of course, no. Because they would want to speak throughout and would want to comment on anything that is within sight. They also have flight of ideas. They have exaggerated type of dressing. What do we mean exaggerated? Often they use bright colors. They will easily be identified from a distance. If they are female, the way they will apply the makeup, it will be in an excessive way. They also indulge themselves in pleasurable activities with painful consequences at the end. For example, increased spending, increased libido, speeding, substance use. They will do everything in an exaggerated manner without consideration of the consequences. They are also highly irritable, meaning they can easily get annoyed. So you've seen that they are difficult people to interact with at some point. You really have to be careful because they are highly irritable. They have increased psychomotor activities. These are the guys that spend much of their energy moving about, doing one or two activities that consume their energy. So it's very important to give these guys food because they spend much of their energy. Even their thought process, they are always thinking. They are also impulsive, like we said in the definition. Some more features. They have elevation of mood, increased irritability, like we stated, flight of ideas, decreased need for sleep, because they are always hyperactive. Decreased attention. How can this person have attention to you when they are always talking, when they have pressure of speech, when they undergo chance association? For sure, they'll have decreased need for sleep, decreased attention. They also have loss of inhibition. What is this? Under normal circumstances, there are certain things that you know that you cannot do in public. You just inhibit yourself from doing such an activity in public or in certain places. But these people, they lose inhibition such that they can do those activities that which you cannot do in public, then they can do them anywhere, meaning they've lost inhibition. They also have psychotic symptoms like delusions, mostly of grandiose and persecutory delusions. They're the commonest. They also have hallucinations, mostly auditory hallucinations. Now, let's look at the investigations or the management of mania. So first of all, you take history, which will review any of the signs and symptoms like decreased attention, loss of inhibition. At least the relatives will give you the history that this person, they have loss of inhibition because they've been doing those activities that which you and I cannot do in public or in certain areas. Other investigations to be done will be based on the DSM-4 or DSM-5 as the latest. There's an experience of elevated mood in these clients. The criteria is as follows. During the period of mood disturbance, at least 3 of the following must have been present to a significant degree. 3 of the following, at least 3. What are these? Inflated self-esteem or grandiose, if that one is present, take note. Decreased need for sleep, take note of that one. More talkative than usual, or pressure to keep talking, flight of ideas, increased goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activities that have a high potential for painful consequences. So if any of the 3 above mentioned is present, then you can actually say someone has mania. Now, how do you actually treat mania? Treatment of mania, you can actually use the following drugs. You can use sodium valproate, which is also sold as valproic acid. You can give 100 milligrams to 250 milligrams twice daily, or thrice daily, or 4 times in 24 hours. This drug is actually a generic drug. It has the following side effects. Someone taking this drug can have sedation, emotional upsets, depression, headache, dizziness, weight gain, diarrhea, vomiting, ataxia. So there we have repeated weight gain in form of increased weight. What is the mechanism of action of this drug? It actually blocks the voltage-gated sodium channels and increased brain levels of gamma aminobutyric acid. The second drug one can use is haloperidol. At least you all know that this drug is a typical antipsychotic drug. It is also sold as HADO, as in HALDOL. It is coming from the group of typical antipsychotics known as the butyrylphenols. So one on mania can be given 2 milligrams to 10 milligrams. of haloperidol. Side effects, they bring about dry mouth, tardive dyskinesia, sedation, ataxia, skin pigmentation, dystonia, and dry eyes. The mechanism of action of this drug, it actually blocks the impulse transmission in dopaminergic neurons. Remember at some point we talked about the predisposing factors to one having mania or mood disorders as being those biological factors where we looked at one having a lot of dopamine, serotonin, norepinephrine. So here is this mechanism of action which says it blocks the impulse transmission in dopaminergic neurons, meaning in one or the other, it blocks the receptors for dopamine. The other drug which have been listed, one can use on someone with mania is chlorpromazine. Chlorpromazine is actually also a typical antipsychotic drug, which is belonging to the phenothiazines group. It also has side effects, just to mention a few: drowsiness, dizziness, and dry mouth. The other drug one can use is clozapine. Clozapine, also sold as Clozaril. It is also an atypical antipsychotic drug. It has the following side effects like weight gain, tremors, headache, constipation, and blurred vision, just mentioned but a few. The other drug which can be used is risperidone, also sold as risperidol. It is also an atypical antipsychotic, which has the following side effects as well: dizziness, drowsiness, dystonia. It also has extrapyramidal reactions, just like haloperidol. It also brings about weight gain. And the other drug that can be used in the management of mania is actually carbamazepine, also sold on the market as Tegretol or Epitol. This one is actually an anticonvulsant, which can also be used to treat bipolars like mania, depression. It can also be used to treat mood disorders. It has side effects as ataxia, dizziness, drowsiness. So these are the drugs that one can use in the treatment or management, rather, of mania. Now, let's look at the nursing management of mania. When you receive a manic patient in your ward, the first thing you should consider is establishing a therapeutic relationship. Remember, this is also in accordance with the nursing model, which was written by Peplau, where he talked about the nurse-patient relationship. So a manic patient, you need to first think of establishing a therapeutic relationship. So the ability to form a therapeutic nurse-patient relationship is rooted in awareness of communication skills, and these may be further organized into an awareness of interaction analysis. The end result being awareness of components of the therapeutic nurse-patient relationship. So what are we saying? The nurse should use a firm and calm approach. Why should your approach be firm? It will show to the patient that you are serious with what you're saying. It needs to be done. But why should be your approach calm? Because these patients are easily irritable. They easily get annoyed. So the nurse should use a firm and calm approach when you're communicating with a patient. You need to be firm because you need to show it out that you're serious with what you're doing and saying. But you need to be calm. This provides structure and control for a patient who is out of control and can also result in feeling of security in the patient. That is feeling that someone is in control when you are serious. When you use firm language, the patient will actually notice that you are serious. The nurse should also use short and concise explanations or statements because the patient's attention span is very poor. Remember, in the signs and symptoms, we've actually mentioned that these people have decreased attention. So as you communicate to these patients, you need to use precise and concise explanation. It is also important to be consistent in approach. This shows you that you're actually very serious as a nurse with what you're saying to this patient and expectations from the patient in order to minimize potential for client to manipulate staff. In this case, frequent staff meetings should be held in order to maintain consistency because you must be agreeable as a group of nurses working in that department that we are going to be doing this thing, and it should be done uniformly on these patients so that they notice that every nurse has the same approach on them. The nursing staff should also firmly redirect energy into more appropriate and constructive channels or activities. We have actually mentioned that these manic patients, they have a lot of energy to waste moving about. This energy can actually be redirected to better activities. Maybe they can be involved in activities of, if they are male, playing soccer, if they are female, playing netball, so that by the time they come back, they would have at least used up their energy in such activities. The other point that the nurse should think of is actually how to maintain a safe environment. So the overactive patient lacks internal control, remember? So limits or external control should be set or put in place by the nursing staff to avoid unnecessary injury to self or to others around the patient. So this may take the form of setting clear limits, meaning they should come up with do's and don'ts, and being consistent in reinforcing them by all the nursing staff. Not this nurse comes to try to reinforce this kind of activity, the other one is a bit on the reluctant side. All the nursing staff should come up with the same way of handling this patient so that they realize actually to say, these nurses are serious with what they're saying and doing. So clearly defined limits provide a framework in which the client is free to function more appropriately, to learn more socially acceptable ways of behaving. So the nurse must communicate to the patient the expectations and use of frequent reminders in order to reinforce positive behavior, especially when the patient does something wrong. Firmly, the nurse must talk about that is not needed in that environment. Then the patient will actually realize that what they've done in one or the other is not right. The principles of behavior modification should be incorporated into the nursing approach, and the nurse must ensure that rational behavior is reinforced. We go back to a bit of psychology where you reinforce rational behavior, especially positive reinforcement. Even just stating to a client when they do something good that this is very good, this is excellent, you're a good person. Such comments will come as positive reinforcement for such a client, and the client will continue doing good because of your positive reinforcement. The other area to consider is nutrition. Remember, we actually stated that these patients, they involve themselves in strenuous activities that consume or deplete their energy levels in their body. So lack of adequate nutrition may lead to complete exhaustion and malnutrition in a hyperactive patient who is too busy to stop and eat in one place. So in this case, meals may be embarked upon, but are often quickly discarded as the patient is too distractible to concentrate on eating. So here, just as nurses allow the patient to eat as they move about, save them meals that they can eat even as they move about. So monitor intake of food and the fluids to ensure adequate fluid and caloric intake to minimize dehydration and malnutrition, respectively. So meals rich in protein and calorie should be offered frequently in small amounts because these patients will not sit down for a long time to eat. This will help to replace the lost energy through their strenuous activities they perform every day. So allow the patient to take small meals, but frequent ones, which are easily taken in when the patient is pacing about. At least this will promote food intake. Because remember, these patients are moving about, losing their energy, and they will not sit down to continuously eat, but they will continue moving about. So save them those meals that will allow them to be eaten as they move around. All you want is to replace the lost energy. The patient also needs to be supported through reminders to eat because they are easily distractible, as he may be unaware of his bodily needs and is easily distractible from concentrating on meals. The nurse must be concerned with the resting and sleep of this patient because we've actually stated that they are hyperactive. They have decreased sleep. The overly active patient may be too restless to sleep. His thought process will unusually remain accelerated and will be hypervigilant, and the time spent in bed may seem like a waste of time. There is danger of exhaustion, and patient is likely to disturb the sleep of other patients in the department because there will be noise, hyperactive, they have decreased time to sleep with their grandiose ideas, pressure of speech. They will disturb other patients in the department. So encourage frequent rest periods during the day to prevent exhaustion and also provide a conducive environment for sleep, such as one with a quiet environment, less stimulants. Stimulants we're referring to noise and movement. Such environments will at least promote rest and sleep. The area should be well ventilated. Or sometimes the nurse should actually think of involving these patients or clients in strenuous activities like football, netball, so that when they come back there, they will be exhausted and they will think of sleep. At night, warm baths can be provided and medication when indicated to help them rest. Remember, we discussed that they have issues to do with the dressing and the cleanliness of their bodies. When they dress, sometimes they overdo it with bright colors. If they're females, they would actually apply a lot of makeup, exaggerated levels of makeup. So we're saying the elated manic patient may show preference for garish or bright colors and improbable combination of items of clothes. So makeup may be excessively and clumsily applied, as we said, and this makes the patient a potential object of ridicule and laughter by fellow patients. And that now ignites irritability in the manic patient because other patients may be ridiculing the patient or laughing at the patient because of the combination of colors. So as nurses, we should help balance up these colors and also ensure if they are female, apply the normal levels of makeup to avoid other patients in the department to start laughing or ridiculing the manic patient. Personal cleansing may be a problem as the patient is too active to concentrate on daily baths. So as nurses, we should come in and ensure the patient has daily baths by encouraging plunge bath, encouraging oral care, encouraging this patient or actually helping at some point to keep their hair clean, ensuring that if they're admitted, their bed is actually well spread all the time. The nurse should supervise choice of clothes, minimize and bizarre dress to lessen potential for ridicule and laughter by fellow patients, which lowers patient self-esteem. Remember, these manic patients actually have a very, very, if not extremely, self-esteem because they also have grandiose ideas here. So anything that will ridicule them lowers their self-esteem. The patient should also be supported by reminding him about need for hygiene and providing necessities where need be. Patient's distractibility and poor concentration can be countered by reminders and simple instructions to the patient. The nurse must also think of elimination for this patient. There is a risk of constipation and dehydration associated with low intake. Therefore, low intake of fluids and food. Therefore, it's important for a nurse to monitor output or bowel habits of this patient. The patient should be offered plenty of fluids and foods rich in fiber to prevent constipation. This is for the reason of preventing fecal impaction, as we stated, resulting from dehydration and decreased peristalsis. The nurse must also consider issues to do with activities and recreation for this manic patient. The nurse should set limits on the amount of time spent by the patient on energy-consuming activities and should attempt to ensure a quiet, calm, and non-stimulating environment for the patients to easily rest. A calm and consistent nursing approach is helpful because these patients are easily irritable, and the nurse may capitalize on the patient's distractibility by diverting attention away from physical activities into conversation because the patient is easily distractible. When they are almost becoming irritable, you can easily, as a nurse, divert their physical activity into a mere conversation because they're easily distractible. Solitary activities requiring short attention span with mild physical exertion are best initially, such as painting or drawings, games, and taking walks with staff. Solitary minimize stimuli and mild physical activities release tension constructively. When the patient is less manic, he may join one or two other patients in quiet, non-stimulating or competitive activities such as board games, drawing, and playing cards. So games of competition should be avoided because they can stimulate aggression in these manic patients and increase psychomotor activity. Protect the client from participation in activities that have negative consequences because they are easily irritable, remember? They can express aggression. The nurse should also consider preparation for discharge for this patient as the patient keeps improving. So this discharge plan should be ongoing throughout patient's admission in hospital and should include the patient's family. So the family of the patient should be fully involved in this discharge plan. They should actually know how you as a nurse, you are planning the discharge for this patient. This should include information, education, and communication about the illness for their relative, treatment, and home care. The relatives should be given full information on the illness of their relative, the treatment, the drugs that the patient is on, the side effects, and how they should take care of the patient home. Psychological support should also be provided through provisions of information on the illness, its treatment, and available sources of help outside the hospital setup. In simpler terms, allow the patient and relatives to ask you questions as a nurse pertaining to MANIA and its management, and answer all the questions promptly to clear their misconceptions. Also, you should be able to explain to the patient and relatives what predisposing factors bring about mania, how to manage it. This will help raise the knowledge base in the patient and relatives. Also ensure that you explain each and every procedure you do on the patient and his or her relatives. This promotes cooperation. Involve some diversional therapy where you involve this patient into activities like football, netball if they are female. This at least diverts the minds of the patient away from money. Risk injuries to self. So that is the general nursing care that you can offer to a patient with mania. Now, for those that would wish to use the nursing care plan, where you have the problem identified, the nursing diagnosis, the goal or the aim, implementation, and evaluation. Here are some of the nursing care problems that can be identified in a patient with mania. Some of them are actual problems. Some of them are potential problems. I hope by now you know the difference between actual problems and potential problems. Actual problems usually will have three characteristics. There will be the problem itself, the cause of the problem, and the manifestation of the problem itself. Whilst the risk usually will just have the problem itself and the cause of the problem. So the first problem is the risk of injury, because these are easily irritable and they get to be aggressive. This injury can be to self or others, related to extreme hyperactivity, destructive behavior, anger directed at the environment, increased agitation. All those are the ones that can easily and nicely cause this problem. There can be risk of violence, which is self-directed or directed at others. related to manic excitement, suspiciousness, paranoid ideations, hallucinations. Sometimes it may not be a risk, but it will be an actual problem, as in violence or violence. Violence, self-directed or directed to others. So when it is an actual problem, there'll be some evidence here. Evidence by body language, clenching of fists, and jaws, hyperactivity, pacing, repetition of verbalization. That's why some of those potential problems have got evidenced. That is meant that at times that can be a risk, at times it can be an actual problem. Like that one which has the risk of injury, the first one. Sometimes it can be actually just injury to self or injury to self and others. So this one can be caused by extreme hyperactivity, destructiveness, anger directed at the environment, increased agitation, evidenced by hitting head, hand or foot against the wall. The third problem can be altered nutrition, less than body requirement, related to refusal or inability to sit still for a long time to eat. We have actually stated that these patients, they don't sit down to concentrate on eating. So they risk losing weight. Sometimes it could be due to lack of appetite, which can be evidenced by loss of weight or the conjunctiva in the eye getting pale. The other problem is the risk of exhaustion related to hyperactivity, pacing, repetition of verbalization. Altered thought process can be another problem related to hereditary, usually evidenced by them having delusions, even hallucinations. Sensory perceptual alteration related to hereditary factors, biochemical imbalance, usually is evidenced by hallucinations, talking and laughing to self, listening, pause. Some patients can also have impaired social interaction due to altered thought process, chance association, flight of ideas, evidenced by client abrupt chance of change of topic of discussion during an interaction. Remember, we mentioned that they have chance association, pressure of speech, distractible, irritability. So they can't have a normal conversation for a long period of time with someone. Sleep pattern disturbance related to hyperactivity. We've actually mentioned that these clients are hyperactive. So they may not have time to sleep or rest. So they will have sleep pattern disturbance related to hyperactivity, evidenced by the high desire to perform physical tasks regardless of time. Whether it's in the night, whatever time, then they would love to perform certain physical activities. And this makes them have a disturbance in their sleep pattern. For today, this discussion, this is where it ends from. From where I come from, today being it a Friday, I would actually say, was a weekend to you all. In my mother tongue, I would say, Dalumbaga Party for your listening. Have a good day and enjoy the rest of the weekend. Thank you so much.